So, thank you very much for joining, if you're joining live, or if you're watching this back. We've had a really good series of webinars over the last 6 months. And I'm really, really excited to hear what Juan Carlos has to say today. I think this topic of caring for the quality of life of dogs and cats and our patients with cancer is a really, really important one. So I've been looking forward to this talk a lot. But before we get to the talk, I'm just going to talk to you about why we're here and what we're here for and here to help you. So, Juan, if you can just move the slide on, that'd be great. Okay, so we're here today to sort of introduce our team, our specialist advice team from VET.CT. So VET.CT, as you know, if you've registered, are a global team of over 200 specialists, and we're essentially here to help you in practice. And as a company, we're global and we specialize in exceptional radiology, which is our first thing. But we also provide specialist written advice and specialist advice through instant messages and phone calls. And we also have an arm that provides education services as well to train residents and students of the future, to support universities in that sort of next level of care as well. So we've got 3 different arms. And today, and all of the webinar series that we've had over the last 6 months, is to introduce the people and our specialist team behind our specialist case advice service. So you can see our clinicians, you can get to know them, and you get to interact with them. So what do? We essentially provide written specialist case advice within 12 to 24 hours. Okay, so this is written advice to treat cases in-house. You can rely on us for really, really fast turnaround times. We say 12 to 24 hours. Often it's sooner. I think on average we get back to people in 2.5 to 6 hours. And one of the unique things about the VET.CT specialist case advice service is that we provide unlimited follow-ups. So we really feel quite strongly that this isn't just a question and then one answer. Cases don't work like that. We've all worked in practice. We all know how to manage cases. And actually, it's a conversation. And sometimes it's a really good collaborative conversation. And we really enjoy this. And we like the way of working with teams in practice. So essentially, we're that specialist extension of your team where you can ask us questions. Once you create the case, that has unlimited follow-ups on that. We provide you with detailed notes to add to the file and keep the owners updated. And actually, overwhelmingly, the feedback is that clients are delighted to stay with the vet that they know and trust. Obviously, there's a place for referral. We're not a replacement for referral. But if they want to stay with the vet that they know and trust, this is a great way of bringing specialists into your workflow. When we talk to the vets that we support, one of the biggest things is reducing uncertainty. It's giving those clear and detailed next steps. So overwhelmingly, our specialist advice doesn't necessarily change things. It sometimes supports the decision-making process. It reduces uncertainty, and it reduces some of that stress that we've all felt in practice as well of the unknown. So it is that extension of your team, and we're here to help you. The way you can use us is 2 ways. So you can access us through the desktop. So if you go to vetct.com, you can access through that. And then also, if you go to the Play Store or App Store or something like that, we have an app. Okay, and the app is fantastic. Some practices obviously don't allow phones, but if you've got a tablet, I would certainly recommend to download the app, because so much of what we do, and including in oncology, neurology, dermatology, ophthalmology, everything like that, is visual. And so much of what we do, if you can send us multimedia, we can give you better information. So you can upload all your bloods, your histories, your photos, anything like that into the case platform. And if you've got the app, I found out the other day, you can actually dictate into it on your phone if you use the microphone as well. So it can take about 3 minutes to submit a case maximum. It's really good. And the way that you can pay for us is that you can get case advice just case by case. You do not need to get a subscription, but we offer subscriptions as well. So if you want any more information on our costs, how you access us, how you can get subscriptions or pay case by case, just click on take a photo of the QR scan, or go to our website and contact us, and we can just give you all the advice that you need. Okay. Next slide, if you can. So if anybody would like a demonstration webinar or a demonstration talk on our platform about how you use our service, then please do get in contact with me, richard.artinstall@vetct.com. Sorry, to introduce myself, I'm Director of Teleconsulting, so I help run the service. Next slide, if we can. So just a bit of housekeeping for this talk, the same as all the other talks if you've joined us as well. This will be recorded afterwards. So everyone that's registered will get a recording afterwards. If you've got any questions, then pop them in the Q&A box, which is at the bottom, and we'll fire those at Juan Carlos at the end. And everyone's on mute for this, so we can't really interact with you through conversation, but we can get those questions at the end. Okay, next slide if we can. Great. So let's get to the talk. So caring for the quality of life of my patient with cancer, really, really important topic on so many levels. It's something that touches all of us in practice, in referral settings, in university settings as well. And it's something that is complex and is multifaceted and involves owners, patients, vets, specialists, the whole team, the whole collaborative team. And we are here to help in those decisions as well through our oncology service. So I'm really pleased to introduce Juan Carlos Serra, who's a specialist in oncology and radiation oncology as well. So exceptionally talented and is the person to talk about this subject. So I will hand over to you, Juan Carlos.
Thank you so much, Richard, for the introduction. Thank you, everyone, for joining us today for talking about quite a relevant topic, especially for general practitioners. So basically, when we speak about oncology and cancer treatments, we hear a lot about how surgery is the most effective treatment for tumor control, especially for solid tumors, and how chemotherapy is life-changing in some fluid tumors like lymphoma or leukemias, how relevant radiotherapy is in controlling local tumors primary tumors that cannot be excised, like brain tumors or nasal tumors. And we also hear a lot about new treatments like immunotherapy, targeted therapy, metronomic therapy that help in the control of the cancer patient, the disease of the cancer patient. But we actually hear relatively little about supportive care, which is actually a mainstay part of the treatment in any patient with cancer. And it's very relevant, especially given that many of the families choose to go for supportive care only. It's very, very frequent nowadays that families will want to support their pets with treatment for their cancer, but also very frequent that they will not want to consider aggressive approaches, either because of ethical concerns, logistics, or finances. So therefore, they end up not wanting to be referred. They end up not wanting to consider complex or expensive treatments, but they do want to give a chance to the pet to try to keep him or her more comfortable for as long as possible. It is important to remember that regardless of the therapeutic approach that we take, the main goal in veterinary oncology is different than in human oncology. So when we're treating a human, we are really focusing on making sure that a little bit kind of like regardless of the severity of the adverse effects, if we can cure this patient, we can do very tough treatments for aiming for that. But in veterinary oncology, the main thing is always to restore, maintain, or improve the quality of life. So you can't just consider any treatment option regardless of the potential consequences that it will have in the patient. Obviously, secondary goal of treatment is going to be prolonging the life expectancy, but this always comes by improving or maintaining that quality of life. That is the biggest important bit, and this is why the supportive care always plays such an important role in treatment of cancer in dogs and cats. So going a little bit backwards, what can impact a patient's quality of life? Why can it be affected if the patient has cancer? Obviously, the tumor itself can have consequences on how the patient feels. The mass itself, if we're talking about a kidney mass, a splenic mass, a bone mass, any type of viscer can cause pain by being distended. So any visceral tumor is painful. And of course, in addition to that, it can bleed and that could cause a problem. It doesn't even have to be like a life-threatening problem. Some dogs that have hemangiosarcoma, they will intermittently have weakness and then suddenly they recover because that blood is absorbed. But that would be one of the potential consequences why a patient can present to the clinic. Obviously, if it's a bone lesion that is eating the bone and decreasing its density, there can be a fracture, and that obviously can have a huge impact on the quality of life of our patient. In addition to the direct effects that tumor can cause, we have indirect effects. So, for example, anything that is paraneoplastic. Paraneoplastic means a consequence of the cancer that is not directly caused by the mass. So, for example, the mass could release substances into the body that can cause fever, cytokines, for example, or there are some tumors like insulinomas that can release excessive insulin and cause hypoglycemia, which can then cause neurological signs or other signs that are systemic. Myasthenia gravis, if we're talking about, for example, a thymoma that is releasing antibodies against the acetylcholine receptors in the muscle. So any of these things kind of impact the quality of life of the patient. But it's not just the cancer that can do that. We have to take into account that frequently these patients will be getting treatment for that cancer. So, for example, a surgery can impact the quality of life of a patient. If you suddenly are removing the tongue of a cat because the cat has a tumor in that site, that obviously would dramatically impact the quality of life of the patient, and it perhaps shouldn't be performed if the patient is not going to eat again. Less radically with that, any patient that is getting chemotherapy would be at risk of getting GI adverse effects or an infection, or with radiation, there might be a lapse of time where we can get a severe dermatitis that can cause pain, and we would have to cover that patient for pain relief and for feeling well during that time. In addition to the treatments and in addition to the cancer itself, we need to speak about comorbidities. We're talking about patients that are geriatric, patients that may have other conditions, and we need to be aware of that, especially because they could complicate the risks of a specific treatment. For example, if a cat had severe heart disease, perhaps he's not the best candidate for undergoing multiple radiation treatments because he will require anesthesia, or an I-131 treatment because he would require to be isolated. Um, a patient might be fine with his cancer, but he could have a severe osteoarthritis as well that is causing pain, or chronic kidney disease, which could affect the way we evaluate the treatment, and we have to consider that it could be too toxic for him and develop differently. So we have to take into account not just the cancer, not just the treatments that we're doing, but also in general the health of the patient, and make sure that we're not forgetting about those, because sometimes we focus so much on the patient having cancer that we don't realize that perhaps there is another issue that is causing the same or even bigger concerns to the patient. So some important points to discuss is that whenever we are seeing a patient and we diagnose a patient with cancer, that patient becomes a chronic patient that needs very frequent rechecks. And at each of those rechecks, we need to evaluate how the quality of life of the patient is. This doesn't involve only during treatment, but even if they did not go for treatment, or even after completing the treatment, we should still be taking how the patient is doing. Again, not only because of the cancer itself, but just because of the comorbidities as well. And often, say the client didn't want to go for any treatment, and we just want to supervise how that patient's doing, adjust the medication that is required to keep the patient comfortable, and advise the family on when the euthanasia needs to be performed, basically when it's time to let him go, and also support them and making that decision, or support them and support the pet as well, make sure that the pet is not suffering. These rechecks also help with determining the remission status, so making sure that if we have treated the patient successfully and the patient is in remission, we detect the relapse early, so we can either act again with cancer treatments, or at least act again with treatments that can make the patient feel better. Here we have a tool that is very, very useful for these rechecks during treatment or after treatment. This is the one that we use at the University of Edinburgh where I work, but obviously you can have your own form. And it's basically just a questionnaire that includes a lot of questions about how the patient's doing. This is something that we use also to save some time. So while the client's waiting, they're filling this form, and then when we receive them in the consult, we very quickly go through the form and see if there are any concerns. It's just a way of not forgetting anything. At the end of the form, you can see on the right, there is a question that says, how would you rate your pet's overall quality of life from 1 to 10? And this is obviously extremely subjective. Some clients the pet will be perfect, but because he or she has cancer, they will already rate like 1, 2 out of 10 just because they don't like the word cancer. Whereas others will say 10 out of 10 even if the pet is really unwell. But it's at least really useful to guide ourselves towards how the family are perceiving the pet is. So if they initially had a 10 out of 10 and suddenly it's dropped to 2, then obviously we have to be concerned. It's just a way of monitoring how their perception is about their life. Because sometimes we'll find those families that are a lot more close and they don't really reflect well on their feelings or their concerns, but when they have to write it, they're a lot more precise and honest about it. So the first thing that we need to evaluate now that we're going to focus now, say that, either independent to the anti-cancer treatment that we choose for the patient, or even if they don't want to go for anything, we have to support that patient, make sure that patient is well. So one of the first things that we need to raise is analgesia. So remember that in general, cancer is painful, and very often the client will say, actually, this dog is he's not my pet's his normal self. He's eating, drinking, happily interacting with family, running, wanting to play. It's very important that we realize that we evaluate what we're dealing with, and even if it doesn't fit with the patient's behavior, we need to be aware that, for example, bone cancer is extremely painful. Painful. Any big mass in the subcutaneous tissue in the skin, any if it's ulcerated, any big visceral mass, any of those are going to be painful, even if the patient is not showing signs. So we can't rely on the family's um, evaluation of the situation. We can't even rely on the way the patient is performing. Another thing that is important to mention is that even though we can start with a specific analgesic plan, we have to continuously monitor it, especially if the patient's cancer is not well controlled, and then modify it accordingly, depending on how the patient is evaluating it and depending on how the cancer is progressing. Not always increasing it, but say that you have prescribed gabapentin and the client suddenly says, oh, the patient is like panting a lot, very unsettled, then obviously it seems like this patient is not tolerating this drug well, or we might be over sedating the patient with analgesia. So either way, we just have to keep a very close eye on it and monitor it as required. Remember that again, we could have pain directly from the cancer. The cancer could destroy bone, it could cause visceral distension, it could cause nerve compression, or indirectly, it could cause release of cytokines that just cause the patient to be unwell, especially this happens with inflammatory cancers, lymphoma, leukemia, histolytic sarcoma, neuropathies can also occur that the cancer in the distance or locally can cause inflammation of the nerves in the body, which can obviously cause pain as well. And of course, we can't forget that treatment can be associated to pain, although we typically recommend always treatments that are going to be well tolerated, surgeries that are going to be well tolerated, chemos or radiations that are going to have acceptable adverse effects. They can cause toxicities, and we have to care for them. We just have to make sure the patient is going to be well. When we're talking about how to deal with analgesia, again, of course, we can aim for surgery. We can remove the tumor. We can remove the affected limb. We can remove a kidney if it's distended and causing pain. We can give radiation, which is a great option for non-resectable bone tumors, for example, or even many of the type of tumors that can shrink, and this can make the patient feel better. We can obviously do chemo for patients that are painful due to these treatments that are tumors that are going to be responsive to chemo. An example would be transmissible venereal tumor, which is basically very responsive to incretin, and it can cause ulcers in the skin or in the genital region. We could use bisphosphonates, which we'll talk about in a minute, which are just special drugs that can remove pain from bone cancer. And then finally, we should always use analgesics. So we will speak about the use of anti-inflammatories. Typically, NSAIDs are a lot better for pain relief, but sometimes the steroids are more relevant for specific cancers. And then from there, we can use paracetamol. Metabusol is not a drug that is used in UK, but it's a drug that is used in many other countries. And it's really helpful for pain relieving dogs. In the UK, metabusol itself is just not a thing because of the fact that humans don't tolerate it in the country very well for genetic reasons, but it's just another drug that can be used in pets and typically is very well tolerated. Gabapentin, amantadine, tramadol is not a drug that we are using that often recently because it seems like dogs don't produce the metabolite that is active, and cats, while it can work, they don't tolerate it well orally. In cats, we use a lot of buprenorphine transmucosally as well. And then obviously we have these new drugs, Vet.CT and Vet.MAP, that we're using a lot now. They're very easy to administer once monthly injections, and they seem to play a role with any type of chronic pain. So they seem to play a role with cancer as well. I put all of these drugs together here, and of course, I don't mean that they should all be prescribed. But these are options. We should start probably with maybe like depending on how painful we feel the patient is, one or two of these drugs, and then escalate it if we feel things are progressing. Regarding bisphosphonates, so bisphosphonates basically are drugs that work by impairing the function of osteoclasts, which are the macrophages that are in the bone. They can be given as oral treatment, like alendronate, for example, but this is a little bit more difficult to dose and it works a little bit less well. And then we also have injection forms like pamidronate or solendronate. They're really useful for pain. That study in the slide described 40% of dogs improving performance, yes, with injections of pamidronate for appendicular osteosarcoma bone pain, which we know is one of the worst pains that we can have. But in addition, they're also really, really helpful. They're given like once monthly when you do it as an injection, or once every 3 to 5 weeks, depending on how well the patient is responding. They're also really useful for calcium homeostasis. So we know that in dogs, it's less frequent in cats, but in dogs, it's very frequent to have a malignancy-induced hypercalcemia. It typically happens in patients with lymphoma, patients with anal adenocarcinoma, patients with multiple myeloma. And basically, while we can obviously control the calcium by killing the cancer, not always this is possible, either because the treatment doesn't work or because the owners don't want to consider it. So it does become part of the supportive care to control that calcium. And these injections are really useful at decreasing the calcium levels and controlling the calcium even if the cancer is not being well controlled. And it's a lot easier to just do like one monthly injections than to be given like oral steroids at home for a very long time because that could have bad consequences. So it's a very useful drug. Again, pamidronate and solendronate and alendronate are very well tolerated and they could be used in practice. Solendronate is the kind of like gold standard drug at the moment because it's the most effective one. And while pamidronate needs like 2 hour infusion, solendronate can be given within 10 to 20 minutes. So it's actually quite straightforward to administer and it's easy to get as well as a source. Regarding anti-inflammatories, it's also kind of like given for granted that any patient that has cancer will be receiving anti-inflammatory treatment. And obviously we have steroids and we have non-steroidal anti-inflammatories. And how do we choose them? So steroids would be the first line on specific tumors like lymphoma, mast cell tumor, plasma cell tumor, T-cystic sarcoma, and central nervous system tumors. In the case of lymphoma, mast cell tumor, and plasma cell tumor, the reason behind using steroids, especially in lymphoma, is that actually it is a cytotoxic drug against this cancer, and we would expect that the tumor will shrink in majority of the patients, and therefore, obviously, it'd be silly to not go for this type of anti-inflammatory drug. Typically, it's given in combination with chemotherapy, but if the chemotherapy cannot be administered for whichever reason, steroids alone should be considered part of palliative care, and they might induce partial responses in many of these patients. In the case of the central nervous system, it is because often these patients will have a lot of edema around the lesion, and what we want is to have a very strong anti-inflammatory effect. This is a more strong anti-inflammatory compared to non-steroidal anti-inflammatories, and it's very frequent that dogs will dramatically improve, or cats will dramatically improve their performance or their well-being once they have started to receive steroids, and this will last often for even a few months if it's left untreated. And then finally, in histamic sarcoma, it's more like if the patient is starting to feel unwell because of all those cytokines that remember that this histamic sarcoma is a tumor that arises from dendritic cells. So it's an inflammatory cell, it can release a lot of cytokines. So it does help with the performance of the patient to consider using this anti-inflammatory. And it's very frequent the patient will be feeling really unwell, and then you prescribe the steroid and there is a dramatic change. Steroids are also very important in patients that have hypercalcemia. They typically will be the first line to act. It's just obviously you give fluids, you can give furosemide in the acute term, but the next thing you do as well is you give steroids. The prednisone is gonna increase the amount of eliminated calcium through the urine. The only thing is that in the long term, the steroids can have more adverse effects. So typically, while this would be like a first step, we would recommend then moving on to something else like bisphosphonates, for example, in the long term to try to avoid this need for long-term steroids. Even though we've said that they should be the first line in the tumor types mentioned, in addition, in any type of cancer, when the patient stops eating, is like really struggling to play and move and is really unhappy, I typically tend to try steroids as the last resource. So basically in terminal cancer, because it kind of like gives them that final push of energy for a few additional days or weeks. So this would be basically the last type of thing you try if the patient hasn't been on steroids yet. Overall, the steroids, they're basically going to be more potent anti-inflammatories. They will increase the appetite of the patient, which is a good thing in patients that are not eating well, and it improves the energy level. So yes, it's kind of like it makes sense as a final resource option for patients that are feeling quite unwell. I typically start with an anti-inflammatory dose, unless it was lymphoma, in which case I would start at 2 mg per kg and then progressively taper it. But for any other type of tumor, typically 0.5 to 1 mg per kilogram. And then you just kind of like increase it if needed, but you also try to decrease it if you can, just because obviously steroids do come with a lot of adverse effects, like they can cause PUPD, they can cause excessive appetite that could be a problem for the families. So and in the long term, it could cause atrophy of the skin and other consequences you want to try to decrease risk of, especially if you're giving this for a significant time, like months. So you would want to use the minimum dose that you can. This would be an example of a dog with a mast cell tumor that is quite aggressive and was quite angry, and we can see a dramatic response thanks to the steroids and how they have decreased that inflammation. And this is a very interesting case as well. So basically, whenever I get a patient referred for radiation, I typically will always recommend steroids prior to the CT just to see what's the reality of the mass. And we have every so and so, because remember that most of the patients with intracranial cancer are diagnosed based on imaging. And while MRI is really, really good at determining the diagnosis of cancer versus non-cancer, it's not 100%, and sometimes we make mistakes. And it wouldn't be a single time, it's been a few times that we have referred ugly tumors like horrible meningiomas or suspected meningiomas or pituitary tumors that end up not being that. This patient specifically was referred to us from Glasgow Uni a few years ago, and it's a published case. It was a young dog, and because of the location and the signalment, we thought it was a craniopharyngioma, and the patient received the steroids. He was acutely blind, received the steroids prior to coming to us, and when he came to us, the client said, actually, he's asymptomatic now. He's recovered his blindness. He's feeling really, really well. And surprise to us, when we go under the MRI, well, when we did the CT scan, actually, the MRI was consecutive. When we did a CT scan to prepare for the treatment of radiation, we find that the mass has disappeared, as you can see on the images below. You can see the arrows pointing the mass and how it's gone on the images below. So it was actually a hypophysitis. It wasn't really a craniopharyngioma or a pituitary tumor, which obviously was great news, but it's just an example of how helpful using steroids can be in patients with cancer slash suspected cancer. And as I said, we always would use steroids for masses in the brain that are not going to be operated on or in the spinal cord. So when do we use anti-inflammatories that are non-steroidal, so non-steroidal anti-inflammatories? We would use it as a first line for any carcinoma or any sarcoma. Okay. The good things of non-steroidal anti-inflammatories is that they're more potent analgesics. So for dogs that are painful, like for example, the patient that you can see in the screen with a rebus or sarcoma, the anti-inflammatories, the non-steroidals will make more sense because they cover better for pain. And in addition, we do know that they can have cytotoxic effects against some carcinomas, specifically very well described for urothelial carcinoma. It's actually the treatment of choice, and non-steroidal anti-inflammatories plus minus chemo. And in addition, it's been shown that non-steroidal anti-inflammatories, because of their anti-COX effect, they have anti-angiogenic effects, so they can reduce the amount of new vessels that are being created, which are required for the patient to be able to eat and to grow. Okay, remember we use the standard dose, so there isn't like a very perfect non-steroidal anti-inflammatory for cancer, but it would be whichever you use would be a standard dosage. This is just from a paper of piroxicam use in patients with urothelial carcinoma, previously called transitional cell carcinoma. And this is just an example of a patient that had gross disease that disappeared following piroxicam treatment. So partial responses and objective responses, including partial responses and even complete responses, have been described with urothelial carcinoma and non-steroidal anti-inflammatories. And I've personally had that experience as well. So we sometimes, when we try one and it doesn't work great, we even change not just the chemo, but also the non-steroidal anti-inflammatory. As I said, there isn't specifically a preference. Some people say that, some oncologists say that piroxicam is the one that induces more responses, but really we don't know that, or if it's just because the papers were using piroxicam, which is a human type of non-steroidal anti-inflammatory. So majority of oncologists do not start with piroxicam. They start with drugs that are actually licensed for dogs or cats, like meloxicam or rabinacoxib. But if these ones don't work, then we can consider this one as a rescue agent. I mean, obviously, the main issue is that it's less well tolerated, and because there isn't any trial study evaluating all of them together and seeing which one is best, we wouldn't really recommend going for a human one as a first line, even if the study suggests that this one might be more effective. So other drugs that we should consider, gastric protectants, for example, they're very commonly used for patients that have muscle tumors. So many times we have dogs that come from other comorbidities, and we do find that some dogs live with their muscle tumors for life. Some of them don't even have to be aggressive, because sometimes they can become inflamed and a little bit larger. In those patients, we always recommend using gastric protectants long term, just because we have seen based on necropsies that dogs with muscle tumors tend to have a higher risk of gastric ulcers, even if they are subclinical. Okay, so using uh, proton pump inhibitors would be my preference, typical like omeprazole, but we could also use some antihistamine drugs like ranitidine, for example. Other than for patients with muscle tumors, gastric tumors as well, of course, would be another indication, just to try to improve the acidity in the stomach and try to decrease the risk of ulcers. In addition, some people, not personally me, but some people also speak about using it for intracranial tumors, because it's been shown that, for example, omeprazole can reduce the amount of production of cerebrospinal fluid. So that would be another indication on some patients, which could help if we suspect that there could be increased intracranial pressure. And then finally, of course, we often would use gastroprotectants to cover for adverse effects, like, for example, chemo-induced vomiting or radiation-induced esophagitis. In the case we have esophagitis, we want to maybe change a little bit the pH of the stomach, so that it doesn't harm so much the mucous membranes of the esophagus, and it doesn't predispose or exacerbate esophagitis that is present. Antihistamines. So obviously with muscle tumors, again, we don't only just give gastroprotectants, but we also typically recommend antihistamines. Specifically for muscle tumors, I personally use loratadine because it's very easy to get, it's cheap, and it's been proven in vitro to have effects against muscle tumors, and it's only given once daily, which makes things a lot easier. Diphenhydramine or chlorpheniramine are given 2-3 times a day, or even 4 times sometimes. Um, and again, for other type of tumors like affecting the skin, it can help itchiness. So, for example, the patient in the screen has lymphoma, it's disseminated, it wasn't responding to treatment, just in palliative care, and adding an antihistamine actually did make a difference for a few weeks to improve his quality of life. Anti-emetics is another type of drug that is really important. So, just because some tumors can cause nausea, if they're in the central nervous system, liver tumors, pancreatic tumors, gastrointestinal tumors, any of these can cause it. And also any patient that is receiving radiation or chemotherapy can have nausea. We actually give maropitant, for example, as a prophylactic when we give doxorubicin, mitoxantrone, carboplatin, because we know these are very pro-emetic, and it's been proven in studies that using prophylactic maropitant is going to decrease the risk of nausea. Maropitant is by far, it's working in the neurokinin 1 receptors, and it works both in the abdomen and so in the gastrointestinal tract and in the central nervous system. It's by far the most frequent and popular drug that we use as an anti-nauseous medication. But ondansetron is also used on top of maropitant if the patient is still nauseous. And then metoclopramide can as well, but it's prokinetic, so it can cause a little bit of diarrhea. So we just have to be a little bit careful with that. And then finally, to finish the talk, I also want to speak about nutrition and euthanasia. It's very frequent that patients with cancer will have decreased appetite, either because of the cancer itself or sometimes because of the treatment. And you can also have cachexia. Cachexia means basically that there is loss of muscle and body condition in general, not just because the patient is eating less, but also just in general because the cancer itself can modify the metabolism and can go into like a more catabolism type of form where the patient is just predisposed to lose weight. And it's been proven clearly that malnutrition is going to decrease the chance of response to treatment. It increases the mortality and morbidity of the patient with cancer, and it's very harmful for the quality of life of the patient. So, because of all of this, we really need to pay attention to the nutrition. In addition, actually, many clients will feel that that's the main thing that they have control over. So they're going to be coming to the vet and they're going to be saying, "What's the diet that you recommend me to give?" And I just wanted to clarify there is no specific diet that is going to cure cancer or make it better for cancer. We don't know that, neither in humans or in dogs or cats. There's going to be a lot of propaganda about supplements and things that can be given, but nothing is definitely known that's going to make a big difference or not. But we definitely want to give a diet that is complete, ideally highly caloric, balanced, and that it has high palatability because we're talking about patients that are not going to have such a good appetite. It can be a home diet, but if that's the case, and some people would prefer that, it'd be ideal to involve a nutritionist. So we make sure that this is a balanced and adequate diet for the patient. Because if we're giving a diet that is unbalanced, that's not a good thing. And very often clients will be focusing on giving just chicken and rice, or just like nice meat or fish. This is not a great idea. We want it to be complete. So ideally, if they want to do it that way, the best would be to involve a nutritionist to give an adequate diet. And then we obviously could have a prescription diet as well. Currently, there are some high level brands that have developed new diets that are prescription diets for patients with cancer, and they basically say that it's extremely palatable and that it's very caloric and also safe to administer without causing other issues to the patient. So basically we do have those diets that can be bought and can be given as well and recommended to the client. It's very important to monitor the body weight. That sometimes we use even as a marker to evaluate response, for example, in cats with lymphoma. And also, it's very important to monitor appetite in the patient because this is a quality of life marker, and it often is going to be what leads to euthanasia in many cases. Just briefly mentioning that obviously we do have ways of supporting the patient nutritionally, like nasopharyngeal tubes, esophagostomy tubes, gastrostomy tubes, or parenteral nutrition. But any of these should only be considered if we, for example, are dealing with a complication or if the patient is recovering from surgery. What we feel is when the patient has gone through that short period of being unwell, the patient will be wanting to eat. If we have, for example, a cat with an oral squamous cell carcinoma that is unresectable and the cat's really painful, I don't think it's a good idea to recommend placing an esophagostomy tube because we're basically leading the client to have a way to like not do euthanasia. If the patient is not wanting to eat because the patient is feeling unwell, then perhaps, and unless we can make that change, perhaps euthanasia should be the way to go. And then finally, the concept of euthanasia. Obviously, euthanasia is always an option as well if the patient is suffering. We don't have to be like, oh yeah, we could use all of these drugs. We can do that. We can also mention, well, if we feel this is not the way to go for him, we can consider euthanasia as well. When we're getting to a point where the patient is not well, we have to start preparing the client for making the decision if we see that maybe perhaps everything that we're doing is not going to make a big change. And one of the things that we can do is we can recommend the patient to keep a quality of life diary. So basically writing down every single day how the patient is doing. I typically tell them to choose like a list of things that the patient likes to do and to write how many of those he or she has done on a day. And if we have a week where most of this is zero or one thing, then they should consider euthanasia. We need to be very supportive. We need to be very um, try to be as kind as possible and as understanding as possible because some people will have, because of ethical reasons or religion reasons, a lot of difficulty. So we have to take it very easy, but we also have to be careful that we support our patient as well. We're not just clients, it's not just the client's needs that we need to cover, it's also the patient's needs. And if we feel the patient's suffering, we really need to get to the bottom of it and get the message to the client that this is what they should be considering. So thank you so much for joining again. And I think this is a good time now if you guys would have any question about the talk, anything that you feel it would be a good time to see. Sam has mentioned, hi Sam, it's nice to know that you're here. Hey JC, if you use steroids to downstage muscle tumor and shrink it preparatively, where do you then advise the surgical margin to be from? That's a really good question. So personally, what I do is I would only use steroids to downstage a muscle tumor if I really feel that is required. So if I feel that the surgery can be done. This is very controversial, so many oncologists will think different. But if I feel the surgery can be done without done staging with steroids, then I wouldn't do it. I would just do a marginal excision. What I mean is, I don't typically recommend doing steroids for shrinking the mass and then be able to get adequate margins. It's only like if the mass is unresectable, then sure, it's unresectable, let's shrink it, and then try to do a marginal excision. So typically, in that case, I would just do a marginal, well, I maybe like add an additional margin, but of like 1 centimeter, but I would be very aware that it might be like a fake margin because steroids can have a cytotoxic effect against muscle tumors. What some other people do, for example, in some institutions in the UK, they will do it as a standard, and I've worked there and I've done it as well, just following the guidelines of the practice. And what they would do is, even if they can do a marginal excision, they want to on stage with the steroids to try to make the surgery a little bit easier and to get better margins. And what they do is they basically roll. Um, with like a permanent marker where the mass was, then they add like 2 centimeters around the region that they marked, if that makes sense. But as I said, I don't typically do it myself that way. I would just prefer to do a marginal excision straight away. But you could do that. You could just mark where the tumor is, and then you can just get margins from the marker that you put rather than from the new like size of the mass. Hopefully that made sense, Sam.
Perfect. Yeah, if you've got any questions, please ask. I've got loads of questions, if that's all right. But I thought it was a fantastic talk and really, really practically useful. So the client questionnaire, I think when I was in general practice and in referral practice, you see patients intermittently, and sometimes you might see them as part of a team. So assessing the quality of life and understanding the quality of life of patients is quite difficult on an intermittent basis. The questionnaire that you mentioned, is that published? I think there was a paper 10 years ago or something that was talking about that. But is that a sort of published paper now that people can reference and use that as a qualitative
It's a funny
questionnaire?
question because I've been asked that a lot from people that just are just wanting to use it for papers. We have published it in publications where we have used it. So for example, we have evaluated this chemotherapy protocol and the quality of life form questionnaire was this one, but we haven't really like done a paper focused on the relevance of this specific quality of life form questionnaire, if that makes sense.
Hmm.
But yeah, it's been published in chemotherapy papers as part of the management of the patient care.
So where would people find that if they wanted to use something like that? I had a quick Google, it didn't pop up straight away,
You
but
would, yeah, so you wouldn't find it as a questionnaire oncology,
yeah,
but if you did look into the patient, if to the papers of
it is.
chemotherapy from Edinburgh University, you will find that some of them will quote that the questionnaire and the question will be shown in there. So I wrote a paper on vinblastine and prednisone and escalating protocol, and that paper, for example, so if you look at Serra et al. Vinblastine escalating, then you can find that paper, and that paper includes the questionnaire. It's part of the paper. Um,
Yeah,
but yeah,
I find it a fascinating area. I used to have sort of a 5 point quality of life explanation to owners about, are they free from pain? Do they have mobility? Can they eat and drink? Are they able to enjoy life? But I think a lot of vets have to make up their own sort of qualitative assessment to guide owners, and then you sort of have to score those as well. So it's a really interesting one. I know in orthopedics, Professor John Innes was looking at client-related outcome measures, which is slightly different, but that was involving the client in the assessment of orthopedic success or not success, in able to guide the clinicians on how things are going, and it'd be an interesting area for me. Okay. Sorry to ask that question, but that was.
No, that was really, I'm actually, you're right that we probably should, as oncologists, like do some type of like review paper about quality of life and an official questionnaire that maybe, one of the big groups like SPONC or,
Mm,
recommend to use. It's a good point.
yeah. Um, if there's any other questions, do ask. I've got another question around um, repeat staging. So you'll see patients back, you can assess them physically, and you may need to sort of repeat stage them. How can we sort of justify that from a quality of life perspective? Because from the patient's perspective, their quality of life might be quite good, and actually, it might involve sedation, anesthetic, finding, I don't know, finding aspirates or something like that. So how do we go about justifying that in those cases?
Yeah. So basically, I think it depends a lot on the patient and on the goal of things. Repeating the staging is going to be useful for multiple reasons. First of all, in a patient with cancer that we have treated, so say, for example, a brain tumor, doing consecutive CTs or MRIs will help understanding how the patient has responded and to monitor closely for relapse of the tumor so that we can then basically proactively act on it and treat before it's causing severe clinical signs for tumors that we cannot see that are just inside the body and we can't evaluate. Say the clients were definitely not going to go for down for any treatment that was like a repeat radiation or repeat surgery or chemotherapy, then probably it loses a little bit of relevance, but still could be helpful at detecting a tumor that could be causing problems to the patient and the patient needing supportive care. And finally, there will be some clients that we just want to know what's going on and they will want to be prepared for what's coming. So that's why staging could be relevant as well. But you do have to take into account how stressful the patient gets when they comes to the practice, how impacting it could be in the families. Would that mean that they then can't pay for treatment if they're going to spend all of the money in rechecks and restaging and CTs and MRI? So I don't think we can do like a general recommendation where we can definitely state that CT scans or MRI serrated or sequences of these are relevant. They're definitely really useful in some cases, but we have to tailor it to the patient, to the family, really.
Yeah, great. We've got another question, just saying, hi, brilliant talk. Thank you very much, of course. Just wondering if you've got any experience with Stelfonta. If so, what are your thoughts on it without being too
Yeah.
controversial, but what are your
So
thoughts?
Stelfonta is a new drug, and it's been really nice to. We always love new drugs in veterinary medicine. It's licensed for dogs, which is also really helpful. So it's basically for people who are not familiar with it. It's an injection that is put into the tumor and causes its necrosis. It has some limitations because it can only be used for relatively small tumors, less than 8 centimeters cubic, and they have to be on the skin, or if it's in the subcutaneous, it's only in specific regions of the body. So that limits a lot the muscle tumors that we can use Stelfonta for. And I guess the main limitation it has is that for those small tumors, you often can do surgery anyway. So really with Stelfonta, you wouldn't be taking any margins either. You're just doing it's kind of like the same as marginal excision. You're just killing the tumor itself without really taking margins around it. And the reporting effective rate is similar to or worse than what you would do, what you would get with a marginal excision. Obviously, it comes with like an open wound that takes 1 to 2 months to heal completely, and it's to me more difficult for the clients to deal with that. But then there are some specific regions, say for example, if it's in a very awkward location of the ear and the client doesn't want to remove the whole ear and it's very difficult to remove them to excise the mass without taking the ear out, things like that, it could become useful. And in awkward sites where it can be very challenging to do an excision, or if the client, or if there is a patient that can't go under anesthetic, or the clients for some reason really don't want the anesthetic to be done, because I guess Stelfonta can be done under deep sedation. Again, it's kind of like also risky to do deep sedation. So typically, when you have a patient that can't go under anesthetic, perhaps deep sedation is even worse, but there are candidates where actually, depending on the location, the type of tumor, that where it could be better. And some clients just don't want to have a surgery done, and they prefer this injection idea. But as I said, we just have to be aware that the healing process is longer. than if you do like a marginal incision with a first intention closure of the wound.
That's great.
It's also not super cheap.
Yeah. Okay. Great. I think if there's any other questions, then please pop them in. I think what's made me reflect on our service and the oncology service, and I think me and JC, we had a chat about this before, is that we're presented a lot of the time with the question, well, what would you do from the client? And it's a really difficult answer to do, and sometimes it's unfair, I think, but clients have always asked that question, what would you do, in so many clinical situations. And I think in cancer oncology, it's difficult to know what to do all the time. And this is a blatant pun for us, but we can help in that decision. At least we can give some objectivity and some expert advice there. So I think if you are presented in practice with those quality of life decisions and what would you do, I think this is a really good opportunity to tap into expertise and just to sort of take that time to say, okay, well, what would the advice be in here and what are the options? And I think that's where we can really collaboratively help as well. So it's an area that we do help in a lot, and I would advise people to use us that way as well. Okay, thank you so much, JC, for the great talk. Really thought-provoking, very practical, exactly what we're here for, and I do thank you for that. If you've got any other questions, then do email them in, and I'm sure we can field them. Everyone should get a recording of this. I think if you could just move the slide on one more. I think we've got one more slide. Yeah, great. So this is the last webinar of the sort of pre-summer series before we go on break, but we'll be having more webinars September, October, November, December. So do click on the scan on the QR code there to see our previous webinars all across different disciplines. They've been really well attended. They're very fascinating. They're all about half an hour, really bite-sized. If you do want to know more about our services, have a look at the website, get in contact with the sales team, or just email me directly at richard.artingsall@vetct.com. And yeah, it's been brilliant. Thank you very much, Juan Carlos. It's been brilliant.
Thank you, everyone. Have a good evening.
Thank you.